Good afternoon and welcome to our Oak Bend Medical Center Happy Hour podcast. My name is Donna and I am your host. Well, we want to welcome back Dr. Carlos C. Munoz. He's a family medicine doctor and a former physician of the year who has been practicing at Oak Bend Medical Center for over 26 years. If you remember, just did a podcast on us with diabetes. And we want to continue that series on diabetes because we feel like that's something everyone needs to know about. So welcome, Dr. Munoz. How are you today?
Thank you, Donna. I'm doing well today.
Good. So last we spoke in general about diabetes and the different testing devices we can use and simple things that we can do to help with diabetes, but we didn't totally cover, a lot of other things. So here we are again. And one of the things we didn't talk about was, can you explain insulin resistance and who it affects?
Of course. You know what insulin resistance is? It's something that is inherited. It's not something that you become. You're born with this defect in which your body is resistant to the insulin that it makes. So what happens is insulin resistance is in the background, let's say, of kids or young adults. And as, kids living here in America, a lot of times, we go get our Happy Meals and get chicken nuggets and fries. And so if you don't get enough exercise and eat the wrong foods, with all the carbohydrates, what can happen is that insulin resistance can start to affect you in terms of starting to affect your insides, where you start to make more insulin to put away or process the carbohydrates that you're eating or that you're not burning away with proper exercise. So you may see some kids who may become overweight, who have signs of insulin resistance, such as the dark skin around the neck, dark skin in the under the arms, maybe in the groin perhaps. But that's a sign that there's just too much insulin in the body. And so the pancreas is the factory for insulin. And so the pancreas is trying to make enough insulin to keep the sugar under control. And so with insulin resistance, it just makes it more difficult for your pancreas in that it has to increase the amount of insulin that it's making just to keep the glucose normal. So if you do a checkup, let's say on somebody who is overweight and has the dark skin, the glucose may be normal. It may be even low, perhaps, because their body is still keeping the glucose low, even though they're making a whole bunch of insulin. So a lot of times for these younger kids or teenagers that come in that I would suspect may have insulin resistance, I may not order just only a glucose. I might order an insulin level. And that's where you can see elevated insulin levels. And then that's where you want to try to change what they're doing, change how they're living and eating to try to prevent it from leading to diabetes one day. But insulin resistance is not diabetes. It's what leads to diabetes, or one of the factors that does.
So that makes sense. You're predisposed. I've always heard you're predisposed for diabetes, but it doesn't manifest till maybe 7 years later or something to that effect.
Correct. Yeah. You may predispose in that you've inherited this insulin resistance gene that. And of course, that's something that you'll see in the families or in certain populations. For example, Hispanics have a lot of insulin resistance in the population. American Indians have a lot. Asians tend to have a lot as well. So, yeah, certain populations, you'll see more insulin resistance. And the more insulin resistance, let's say, the more likely it is to develop diabetes at a younger age.
So I would imagine it's good to get in with the doctor if you have a family history or if you notice some of the signs and stuff, or just come for your annual physicals.
That's right. So if you have a family history of diabetes, it's important to just get your yearly checkup. And yeah, if you've got kids who may have signs, or I would just have them get their fasting glucose and maybe perhaps even an insulin level checked just to make sure that it's not brewing in the background.
So is pre-diabetes the same as insulin resistance, or is it different?
So pre-diabetes is the next step in the progression towards diabetes. So let's say if you have somebody who's 20 and they're overweight, they've got the dark skin around their neck, and they come in for a checkup and their sugar may be normal. So that person I would label insulin resistant syndrome. Let's say maybe a 20-year-old female who has extra weight and has the dark skin. And let's say the gynecologist finds a lot of cysts on the ovaries, polycystic ovaries, that would be labeled as insulin resistant if their glucose is normal. Now, let's say if you take that same individual and 5 years later, they come in for a physical, now they're 25 and their weight hasn't changed, their diet hasn't changed. You know what? Their sugar may be abnormal, and a normal glucose when you're fasting is less than 100. And so let's say they come in and their glucose is 105, 106, 107, 108. Normal, less than 100. The pre-diabetic range is 100 to 125. Once it hits 126, you're technically diabetic. So let's say somebody comes in for their checkup and they're 112. That's a person that I would say is pre-diabetic. Somebody who's insulin resistant, you really got to hammer home the need for diet, cardio, exercise. You want to try to increase your metabolism. That way your muscles will start consuming the glucose even while you're resting. So if you can get them to change their lifestyle, you can stop the prediabetes, reverse it, and help delay diabetes or help prevent it one day.
Great information. Now, medication has changed so much over the years. And the one thing I've noticed is metformin seems to be a long-time diabetic medication. And a lot of diabetics still take it today. Why is it almost a choice of medication?
You know what? Metformin has been out for, a decade. It's turned out that it helps diabetes in different ways. It helps lower the glucose. And one of the problems with diabetes is that you make glucose at nighttime. Your liver is a factory for glucose at night. And so I just had a patient today calling in the nurse asking why the sugar was higher in the morning than when she went to bed the night before. And so what happens is your liver's making glucose all night long, hepatic gluconeogenesis. And so metformin stops that. Or not only stop, it may lower it. And so that you decrease the output of glucose at nighttime. So metformin helps that. Metformin also helps your muscles become more sensitive to insulin. And that way your insulin that you make in your own pancreas works better. So it helps lower the insulin resistance. Yeah, metformin is cheap. It's dirt cheap. You can get it anywhere. It doesn't require prior authorization. You can probably get it for $5 for a 90-day supply. It's typically a twice a day medicine. The only people that can't take metformin are people who have, let's say their kidney function is not doing well. Let's say if somebody has been diabetic for a long time and haven't taken care of themselves, the sugar's been high, the sugar will damage the kidneys. So at a certain point, the kidney function will become abnormal. And at that point, actually, not only metformin, but there's a lot of medicines you have to take them off of. You have to really be careful of. It could be ibuprofen, blood pressure medicines, metformin. There's certain meds you would stop in that situation. But overall, metformin is a safe med. And in fact, some gynecologists have prescribed it to, I've read accounts of, pregnant women getting metformin. But it's used a lot to help women perhaps reverse the polycystic ovary infertility. Some doctors have prescribed it. I've heard some doctors prescribe it to help induce weight loss, though I have not really seen the benefit for that. You could use it in a insulin resistant individual who you really feel that is headed towards diabetes. Definitely you could use it in somebody who's pre-diabetes and as one of the first medicines for a diabetic.
Okay, good advice. It gives us information when we go to our doctor to ask those questions. There are so many different choices today than there used to be. There are injections once a week, injections once a day. There's pills, there's all kinds of stuff. How do you navigate through all this and know what's best for you?
So from the doctor's point of view, if somebody comes in for a physical and let's say they've never known they were diabetic, let's say their physical, it turns out their sugar's 300, sugar's out of control. You want to get something besides diet and you want to get them on diet and exercise, but you really want to introduce them to something that's going to bring the glucose down a little bit faster. And so, for example, my preference, if they have normal kidneys, I would probably give them one of the older medications like glipizide, glyburide with metformin to help bring down that glucose. in that situation. A lot of times, somebody who's never taken any diabetic medicine, didn't really know that they were diabetic, you could get some good results with that. Now, if somebody has been a diabetic for a while, sometimes using these older meds like glipizide may not be quite as effective. What happens is over time, the pancreas is making lots and lots of insulin, trying to keep the glucose down, that it starts to falter. And so the cells in the pancreas make less insulin because they start to falter. And so some of the meds that depend on the pancreas making insulin don't work as well in somebody who's been a diabetic for a long time. So some of the newer medicines, it doesn't matter if you've been a diabetic for a long time or just got diagnosed. Some of these medicines nowadays, they really help lower the glucose. For example, some of these once a week injections like Ozempic or Trulicity, they help actually restore some of the function of the cells that were no longer making insulin. And you can really see some improvement, really see some decreases in glucose with some of these once a week shots. Those shots, unfortunately, are expensive and you need insurance. So a lot of times, the limiting factor on those kind of meds, you've got to have an insurance that will pay for those meds because the price, I mean, easily gets over $700 for month supplies for some of those if you had to pay for it cash. So as from my point of view, as a doctor, I look at metformin, and then it just depends on what kind of patient we're looking at. Is this a new diagnosis, an established diagnosis? Have they tried this or that med before? And so treating diabetes is you try to use the different tools in your bag. So metformin, maybe perhaps a glipizide. There's some other tablets that you can use. For example, Actos has been around for a long time. It's generic now, pioglitazone. It's a once a day. It's not for everybody. You can't use it in patients with heart failure because it might make them swell. There's other ones that Januvia has been around for about 12 years and it's about to go generic. It works okay. It's not the biggest hammer in the tool bag, but it helps some. But some of these new injections really, really help. And along with the new tablets, like, for example, Jardiance, Farxiga, some of these once a day tablets like that, they're not cheap either, but they do really help get rid of the glucose. And they appear to have some other benefits. Jardiance has some benefits. The cardiologists are starting to use it because it helps heart failure. Zigduo apparently has some protective effects on the kidneys. And so there's some benefits to these meds. Once again, you've got to select the right patient because you don't want to give, let's say, somebody whose kidneys are about to fail or really poorly functioning kidneys, you don't want to give them some of these meds. Just have to pick and choose and how long they've been diabetic, see what they've tried, and the kidney function. That's key.
So there's not one size fits all for the diabetic 2 patient in treating them. It sounds like it's very individualized. So I always know patients tend to talk to each other and say, well, my doctor gave me this. And, probably best to listen to your doctor and go with his judgment.
Definitely, because the treatment is individualized because you could have, let's say, a 300-pound guy whose sugar may be 150. And really, it may be a little bit high, but not out of control. Then the next patient could weigh, 150 pounds and their sugar is 400. You've got to individualize the treatment. One tablet for one person may be way too strong for the next person in the next room. So, you have to look at each patient individually.
Okay. So a lot of us, our blood sugar is high. How do we get that down besides medication? What if it's higher than it should be and we want to try to move it down faster? Is there a way to do that?
Yes. What I tell my patients is, look, we've got to make changes to the diet, and what I try to focus on is the carbohydrates. Carbohydrates is a fancy way of saying sugar. And so, a lot of us are just used to eating breads and rice and beans and Mexican food and all the chips and everything. That's exactly the food that is going to make your sugar high if you're diabetic and make you gain weight too. But so what I do is I just kind of review what kind of foods they like to eat. What are you used to eating? For example, in the morning, do you eat cereal? Of course, cereal is pure carbohydrates. Even the quote healthy cereals have a lot of carbohydrates, and that's going to make your sugar higher. Milk has some carbohydrates in it too. So I'd say, how about maybe instead of the cereal, how about maybe an egg or two and maybe a piece of toast with some butter or a little bit of jelly. Jelly's got some sugar in it too, but just a little bit would be okay. Um, so yeah, the focus is just to try to reduce the amount of carbohydrates in the diet and maybe move it over towards a balance of protein and just a little carbohydrates, not too many, maybe limit it to maybe 30, 40 grams per meal.
So, why is it important for us to take ACE inhibitors and cholesterol medicine and stuff with diabetes? A lot of times you'll see that prescribed.
Good question. The ACE inhibitors are blood pressure tablets, and they were discovered to have beneficial effects beyond lowering the blood pressure. The ACE inhibitors, for example, lisinopril is probably the most common one. Lisinopril lowers the blood pressure. It also helps protect the kidneys from the sugar. And so it helps defend the kidneys from direct damage from the glucose to the blood vessels in the kidneys. So you can help delay kidney damage in somebody whose sugar is high or who has already experienced damage to the kidneys. So a lot of times I have prescribed lisinopril in a tiny dose to help protect the kidneys, let's say in somebody who has normal blood pressure, but whose urine shows signs of diabetic kidney damage. So a tiny dose of lisinopril, and what I mean by that is the normal dose for lisinopril for blood pressure would be starting off at 10 milligrams, and you could increase it up to 80. But a tiny dose would be maybe 2.5 or 5 milligrams, not enough to lower the glucose, but enough to protect the kidneys. So ACE inhibitors are pretty important to help protect somebody's kidneys from the sugar. We've got newer medicines now. There's some new medicines out that help protect the kidneys further. They're new, expensive though. Lisinopril has been out for decades and it's dirt cheap. The statin medicines, the cholesterol medicines, they of course lower the cholesterol. And the problem with diabetes is that your blood gets thick. If your blood is thick, it's more likely to clog your arteries and cause problems. So yes, you want to lower your glucose, you want to lower your blood pressure and lower the cholesterol. If you can lower your cholesterol, you can help delay blockages of the arteries. Statins are, yeah, mostly all generic. I think there's one that's still name brand. They work. They do help stabilize the lining of the arteries so that what's in the arteries doesn't stick to the lining and cause blockages.
So, they're all important to take, even though you may not have high cholesterol, they still serve a purpose when we're
They do.
talking about diabetes.
That's right. And so when you're talking about cholesterol, of course, we have cholesterol. We have good cholesterol called HDL. We have bad cholesterol called LDL. And then a cousin of cholesterol, triglycerides. The LDL is what we focus on when you're talking about the statin medications. Your goal is to try to lower that LDL cholesterol to less than 70. So if you can get that below 70, you can help delay the buildup of the cholesterol in the arteries.
So, Dr. Munoz, we talk about steroids and antibiotics can affect our blood sugar, so we need to be careful. What does that actually mean?
You know what? Steroids are used for all sorts of conditions. I mean, an athlete or somebody with joint pain could get a shot of steroids, maybe tablets of steroids. They increase your glucose. I mean, you could have somebody who's not diabetic and they're taking steroids and their glucose will go high. So I typically tell people, look, your sugar is going to go high, but you're wheezing or you've got COPD and you need the steroids to help you breathe. So let me give you some steroids, but you've got to check your sugars because they're going to be high for a while. And the steroid effect can last for, especially if somebody's in the hospital getting IV steroids, the high glucose can last for, maybe a couple of weeks afterwards. So yes, steroids directly affect, they will raise your glucose instantly. What's odd is that your sugar could go from 100 to maybe 300 back down to 100. I mean, it could be just a roller coaster up and down with the steroids. The antibiotics, mostly when I prescribe antibiotics, let's say for a sinus infection, bronchitis, or maybe a skin infection, may not see too much of an effect on the glucose. There was an antibiotic that isn't used too much anymore, an oral antibiotic that was used for sinus infections and bronchitis that, yeah, you had to really kind of watch the glucose. But for most infections, the antibiotic I haven't seen too much of an effect on the glucose. Now, I will say that infections in general, whether it's a UTI or whether it's a sinus infection or a skin infection, appendicitis or whatever kind of infection it is, infections will raise your glucose. And you'll see that's just one of the symptoms that something's going on, is that you may have had a good glucose control, and then all of a sudden your sugars are starting to go up and you start to get chills and cough and cold. And it's just one of the signs of infection that the glucose starts going up.
There's just so much to diabetes and all these things that it can affect. Um, so then we hear make sure you do your eye appointments, your feet, take care of your hands, your teeth. What does that all have to do with diabetes?
So if you're diabetic, one of the effects is on the eyes in particular. You want to get your eyes examined because the sugar will start to, and it's typically, in let's say an uncontrolled diabetic, the glucose actually stimulate growth of blood vessels in the back of the eye, the retina. And so that's not good because those blood vessels tend to twist and snake and make their way through the back of the eye, and they can start to leak blood. And so if you have a little blood vessel in the back of the eye that pops, well, all of a sudden the blood and you can't see. So yeah, you want to get your eyes checked at least once a year. And so if the eye doctor does see some blood vessels growing back there, a lot of times they can use a laser to zap those blood vessels and preserve your vision, prevent vision loss. Because once you have a bleed inside the eye, I've had a couple of patients get surgery, but it's just not quite the same. You do lose vision. So it's better to prevent, definitely better to prevent. And of course, the dentist, yes, you want to see the dentist because if you've got an ongoing dental infection, remember we talked about infections, an ongoing dental infection, yeah, your sugars are going to fluctuate. They're going to go up and down just in response to the infection. So it's important to get gingivitis taken care of. And of course, with gingivitis, you introduce bacteria directly into the blood. So that's not healthy long-term. Vascular, maybe heart issues. But yeah, it's important to get the gums under control. Then the feet, yes, you want to have the patient examine their feet just to make sure that there aren't any sores that they haven't noticed. A lot of times, if a diabetic, a long-standing diabetic has numbness in the feet from the glucose damaging the nerves, makes the feet numb. And it's primarily the feet that are affected. It starts with the toes, the bottom of the foot, and starts to go up maybe towards the ankle and up the leg. That's called diabetic neuropathy. So it's important to have the patient look at their feet or have the spouse look at the feet and just make sure there aren't any little cuts or sores. Because if you have somebody whose feet are numb, they may not feel that little pebble in the shoe that's causing the sore. And they may not notice that there's blood in the shoe until they take their shoes off and maybe look at the sock and happen to notice something. So yeah, you just want to have somebody just monitor their feet, just look at your feet, make sure that they look okay, especially if you can't feel or if you don't have that sensation in the feet.
Right. So it sounds like diabetes can be very complicating and that we need to really be conscious and do our due diligence to take care of ourselves, or this can go bad quick. It's a livable disease, but we need to do what we need to do. So, my last question, can type 2 diabetes be cured?
You know what? The answer is sometimes. Say if you have somebody who's been diabetic for, let's say, 20 years and they don't weigh very much, let's say it's a guy and he comes in and weighs 140 pounds, probably not going to cure it. You're going to manage it. Now, let's say if you have somebody who comes in, let's say maybe somebody who's in their 30s and weighs 300 pounds. I have seen people who have cured their diabetes with weight loss. If you can catch it early, that's the best time to cure it because you still have cells in the pancreas that make enough insulin to control the sugar. So if you get them to lose weight, a lot of times you can really reduce that insulin resistance within the body to a minimum level. and they can start to get normal blood glucose. I've had some patients who have had thinking of a couple who went to Mexico for the gastric sleeve. They got rid of high blood pressure, cholesterol, diabetes. I mean, no meds. I mean, lost over 100 pounds, and they were cured. So it just depends if you can intervene early enough, might just reverse it. But yeah, if you have somebody who's been diabetic for a long time, chances of doing that are not as good unless there's an opportunity for them to lose weight.
Right. But by compliance and everything, you can pretty much keep your fingers in your toes and everything else if you're in compliance.
Right. And so yes, so we know that if you keep your glucose, the hemoglobin A1C level less than 7, chances of losing your toes or going blind or having kidney damage goes way down. So yes, if you can keep your levels down, you could live your whole life managing the diabetes.
Dr. Munoz, I feel like we've accomplished a lot today, but I still think we have a lot more to accomplish in our education process. Would you be willing to come back and educate us some more?
Yeah, of course, Donna, I'd love to.
Okay, well, I'm going to give it to my listeners. We'll be posting our email. And if you have questions you want us to bring up on this podcast as it relates to diabetes or the symptoms of, send us an email. We'll be glad to put it in the podcast. Dr. Munoz has graciously given us time and helping us educate and navigate. Dr. Munoz, I want to thank you again for joining us today and helping to educate us. And a big thank you to all our listeners for tuning in. Beginning now, setting an intention and a relentless focus on living your life as the greatest person you can be in all situations. Please join us next week.
Thank you for joining us today on Oak Bend Medical Center Happy Hour podcast. We hope you enjoyed today's broadcast and invite you to email us at oakbendhappyhourpodcast@obmc.org with any questions or topics that you would like for us to cover. Remember, you can find us here each Friday at 5. Until next week, be mindful and stay healthy.